Hey, welcome, folks. Have you ever heard about treating arthritis with radiation treatment? You're about to. Stay tuned to the Bone and Joint Playbook with Dr. Urse.
Welcome to the Bone and Joint Playbook with Dr. Urse, where we explore an extensive range of orthopedic topics and insights. Our goal is to help you understand the available orthopedic options and treatments available, and hopefully give you some answers to questions you might have. We want to thank our following sponsors.
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted. Ted's is available online at tedsalladdressing.com.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup@stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
Hello, Dr. John. Welcome back for another episode of the Bone and Joint Playbook. How are you doing?
Doing great, Terry. How are you?
You look good.
Thanks.
All right. So tell us about this guy here. Who is he and why is he here?
Well, we're real happy to have Anthony Paravati. He's a MBA and MD dual trained from Dartmouth University. It's an Ivy League school for you foreigners. We're really pleased we have him. There was an old saying, the only way to get someone from the East Coast to the Midwest is to move the ocean. But he's here. And
That's funny.
He's a physician executive, but he's an oncology leader here in Dayton, Ohio, with over 15 years of experience as a executive medical director for the oncology service line. And he's a radiation oncologist here at the Kettering Network in Dayton, Ohio. He's also very well known as a national speaker. He does oncology reimbursement and healthcare policy nationally, sits on a lot of health policy function boards, and also serves as a kind of a vehicle for patients to get approval for some of the things we're going to talk about today. Does the insurance cover it? Does healthcare policy think it's a viable form of treatment for some of these conditions? And we want to get his opinion on that. He also is a co-founder and a co-host of his own podcast called Value Health Voices, which is a platform that talks about some of the integration of business and healthcare in the over $4 trillion United States healthcare system. So we're real pleased to have Dr. Paravati here with us. Welcome.
Thank you. Thanks, guys, for having me. I'm really excited.
Was that long enough of an introduction?
It was plenty long. Too long.
Well,
so,
he's got good qualifications. We want to tell people they've got somebody here who's got some training.
So help me out a little bit. Oncology, is it that the treatment of cancer?
That's right. Yes.
So we're here to talk about arthritis. How did we get here? Right?
Yeah.
How does this radiation treatment apply to arthritis?
Sure. Well, the use of radiation therapy for non-cancer conditions is not a new idea. It's not new in the United States. It's not new around the world. We treat everything from conditions like meningiomas to benign tumors in various parts of the body. And we've been doing that for a long time. The whole business of treating arthritis and other inflammatory conditions is something that's also been going on for a long time. A lot of patients treated around the world, particularly Europe. The use of this in the United States has really grown over the last 5 years or so.
Okay.
There's quite a disparity, though, of how many, radiation oncologists do that type of treatment in Europe versus the United States, right?
Yes.
It's like how many in Europe would be using these modalities?
Widespread. I mean, in fact, they generally refer to themselves not as radiation oncologists like we use in the U.S., but rather radiation therapists, and giving radiation therapy. They speak in those terms, the wide therapeutic use of radiation, not just for oncologic indications.
So cancer and non-cancer or benign things. So things like, we're going to talk a little bit about arthritis, painful heel syndrome, some of these hand conditions, arthritis affects it, but also some of these bent finger conditions we'll talk about.
Yes.
And those things are certainly not cancer related, and none of today's talk will be about that. It'll be the much lower doses, which I'm sure Terry was asking me about earlier, like, how much does this radiation going to do compared to a chest x-ray
or a tooth, getting your tooth x-ray.
Getting things
so
like.
before we do that, why don't we set the stage a little bit? explain in layman's terms what arthritis is. Let's go ahead and remind folks what arthritis is, and then maybe how radiation would treat that.
Sure. So these are inflammatory, often chronic inflammatory conditions of the joints, of the bones, and they can do things like narrow the joint space, so the spaces between the bones becoming narrow, and even result in some what we would call like abnormal bone growth that then narrow spaces can even cause things like nerve pain if it's a tight area in the body, like especially the spine. So it's fundamentally a chronic inflammatory condition involving bones and joints. And then the second part of your question was, why does radiation?
Well, I want to make sure, like he used to say bone, the chicken bone, like the gristle in the chicken bone.
Right, that's the cartilage, the white stuff you see at the end of a chicken
And
bone.
when that
wears down, as he talked about, the joint gets narrower, and when bones start to get closer to each other, that makes more inflammation in the joint, almost like a brake shoe pad on a car wearing down.
Yeah. So how would radiation
what we're trying to do is recognize these a little earlier than the advanced stages.
Yeah.
We're trying to delay things like joint replacements. We've talked about safe alternatives before. We know some of the anti-inflammatory medicines can hurt your stomach or kidneys, certainly in certain populations like diabetics and people with bleeding ulcers. So we want to know, what can we do to get people at age 90 with their body parts? Arthritis affects men and women, hands, hips, knees, lesser in shoulders and ankles. So things that are debilitating people, a lot more things kill people in the United States medically, like heart disease, cancer, diabetes. But things that debilitate people are arthritis, painful, swollen joints, and things that can modulate that are safe are good options to tell people. So today we're going to talk about a low-dose radiation treatment for
I guess
some
I'm going
arthritis.
to get right to the fact.
Yeah.
How, if I'm bone on bone, how does radiation improve that?
Well, radiation isn't going to undo the fact that
Okay.
the joint space is narrow or that the bone on bone. But the reason why the bone on bone causes a problem is from chronic inflammation that is mediated or caused by cells in our immune system. And it turns out that subtype of those cells that promote the inflammation, they are really, really sensitive to radiation therapy. So we use a very low dose, a dose so low that the bones, the cartilage, the muscles, all those cell types, they don't even see it. They don't care about it. But the cell that is the culprit here, macrophages and monocytes, those cells are, as again, I said, part of our immune system, they die off. And when they don't die, so there's two things going on. Radiation can kill those cells, for temporarily,
right,
in a very clean way. That meaning the death of the cells doesn't propagate more inflammation. That's one thing. The other thing is these cells exist in two different states. They exist in an active or pro-inflammation state, and they exist in a kind of a hibernating state. And so the radiation, turns out, flips the cells from the active state where they're causing inflammation to just sitting there and doing nothing.
And there's a lot of people, we talked about x-rays aren't what we do when we treat people. We treat their symptoms. We have people with x-rays that look bad, and they go, my knee doesn't even hurt, or my hip doesn't hurt. But they said, I need a new hip. I go, no, you don't, because you're not hurting. So what is turning on or off those pain generators in a joint? I often see people with two bad knees on x-rays. I go, wow, both your knees look really bad. She goes, well, this one hurts. My Great Dane ran into it. Well, all of a sudden, you've traumatized it. You stirred up the pot. The inflammatory tissues are now inflamed. And then instead of using a medicine to decrease that inflammation, this is a safe alternative that turns off some of those inflammatory, they call them mediators or propagators, that that's what you want to do, is try to cut back the symptoms, maybe reduce some of the side effects of drugs or medicines that can be harmful, maybe avoid thinking of having a new knee replacement or something. And we're not ever going to do, any miraculous improvement of those x-rays. We talked a little bit about some of the biologics, the PRP and stem cells. They don't make the joint x-ray look normal unless you're in a Sky Mall magazine and they show you that guy before and after picture. But honestly, our job as healthcare providers is to look through our literature, look through the science of it, figure out the correct dosing, frequency, and that's some of the expertise his field has.
So if I'm watching this and I'm at home and it's boy, my arthritis hurts, do they just reach out to you and say, hey, I saw this podcast where you're treating these things with low dose radiation? Is that how this would work, or does a doctor refer people to you? How does this?
People both self-refer and also, physicians refer to us. And patients can actually, for our institution, if they look us up or look up low-dose radiation therapy, Kettering Health, they can actually self-schedule. So they'll be asked a couple of questions, and at the end of that process of those questions, if they're answered in such a way that's consistent with this individual having osteoarthritis, they can book online an appointment with us just right there. They don't even have to call. And then we'll see them. We'll review their x-rays if they have them. We'll talk through what treatments they've already had and that haven't helped. And then if they are a candidate, we'll do it.
So let's go through the joints where this is. You can apply this. Is it everywhere, or is it certain hands and knees, or where can this work and where can it not work?
Yeah. So there's varying amounts of data, varying data quality for the studies that have been done looking at different joints in the body. I'll say right away that because the Germans have been doing this for so long, they've treated many tens of thousands of patients across many joints, from the major joints like the knee, low back, small joints like those of the hands.
Right.
And their data would suggest that from different joint types, that anywhere from like 65% to 80% of patients have a clinically meaningful improvement, meaning the patient rates themselves that the pain is improved from having the treatment. And what they do for that is they'll give a round of the treatment, which is 6 radiation sessions, very low dose. We measure radiation doses in gray when we give radiation to a human.
Right.
And so you give half a gray of radiation 6 times. So that's 3 gray total, doing the math. And then if the patient still has some pain, they still have bother from it, then 3 months later, we bring them back and repeat the exact same thing, which ought to give the message that this is very safe, because if you can just give the exact same radiation dose a second time, you already know you're talking about very low, because in most of the low radiation, because in most of the world that we're operating in, much higher doses for, rectal cancer or lung cancer or brain cancers. We don't just voluntarily come back 3 months later and give the same regimen, right? That would create serious side effects for the patient. Right. In this context, it doesn't.
And is this something that is a very narrow beam you're shooting at something, or is this like you're going into a big giant body scanner and you're just shooting me with radiation?
We just target the affected joint. So we create a radiation target, a radiation field. So let's say the knee. So here's my knee right here. We would treat across the joint space, where that inflammation is likely to be, and that's it. We're not going to give.
How long does that last? I mean, how long is the treatment? How long am I in there for 10 minutes? I'm in there for
treatment sessions very fast. We schedule them for 15-minute windows, but the patient's going to be off the treatment table in 3-4 minutes.
Really?
Yeah.
And a lot of these will be, thanks to some of the work he's done maybe with the insurance companies, some are covered by some of the major insurance carriers. And, that is I don't want to call it an alternative therapy. If it's being paid for, it's a therapeutic modality. And therefore, the patient has another option to use his insurance for a safe alternative for treating his arthritis or hers. And there's some other conditions we'll talk about, but, that's part of what you would interview your radiation oncologist about, to say, well, if I'm going to get this done, I mean, how much is it going to cost me? Does my insurance, can you put in a request for approval? And then they probably have looked at the evidence he's provided and said, gosh, we're saving our insurance company a $50,000 joint replacement cost for that knee. Maybe we'd approve some of these visits for a safer alternative.
Yes, and by now, vast majority of U.S. health insurance companies approve this. We don't have difficulty. There's a couple of situations here or there where we've had to go back and forth to get the treatments approved for patients. But again, at our institution, at Kettering Health, we take care of all of that. We don't even make the patients write their own appeal letters. We have a situation going on right now where Medicaid, I think it's actually from a neighboring state, where patients here some of the time they want to have treatment with us. They're denying it, not because it's a neighboring state, but denying it because they think it's not medically necessary. We handle the whole appeal process for them. Patient doesn't have to worry about anything. Once we obtain that approval, then we'll do the therapy. And it's not an emergency. Of course, we don't want people to suffer in pain, but we don't want to just charge ahead and treat somebody and then have the insurance later say, you know what, you guys did that without approval.
Right.
We're not going to pay for it, and creates a whole mess. No, we handle it.
So let's say I come in, I have some arthritis here in my elbow. Mm-hmm. You treat me, and then when am I going to say that's fading away? Can I keep getting treatments? Like, is it like a cortisone shot, or is this something that I get once or twice and that's it? You've done.
Yeah. So let's talk about the period after treatment's been given, when a patient is going to have the feeling whether or not it's working.
Yeah.
We generally see or think about between 2 weeks after the last dose has been given up to 3 months, and so we generally do not repeat that course of radiation until that 3-month time point. We let that time run. We don't, try to jump and short circuit that.
And they don't need therapy for all this. This is just, they've got the treatment, go home, take it easy, kind of see what your body reacts to it and adjust.
Have your follow-up with us, tell us how you're doing, and then we would do it a second time. Can you do it more times? That starts to get where there's not a lot of evidence, not a lot of data supporting that. But from a safety standpoint, especially in the typical person, let's say in their 60s, 70s, they've had now 3 gray a second time, so that's 6 gray, still very, very low risk of any kind of complications.
Just what's a tooth? Give me a gray rating for a tooth X-ray.
Oh, that's going to be, in the thousandth of a gray, quite low. Yeah, it's going to be very low. In fact, we don't even measure them in gray then, because it's sort of difficult to be, like millisieverts or some such thing would be the radiation unit that we would use for that. But you can think about the getting a whole course of radiation for this as getting like 1 CT scan in terms of the total dose.
That's not bad at all.
No.
Okay.
Yeah. In that kind of a range.
You won't glow in the dark.
But also,
you won't glow in the dark.
You're not going to glow in the dark. But the other thing, too, is that radiation has relevance not only in the dose, but over how much time it's given, right? This is broken over 6 days. It's not like one episode of radiation exposure.
Also, I'll come to you 6 times in a row?
You'll come 6 times every other day. That's the protocol.
One time every other day.
That's right. So it'd be like Monday, Wednesday, Friday,
Weekends
Monday, Wednesday,
off.
Friday, and then you're done.
Yeah. Okay.
It's all golf.
Just weekends off. But this is important. So again, it's a function of the radiation dose is being given over time. It's not just one exposure event, so that lets the body heal. But also, this is not like if a patient has a PET scan, think about that, a PET scan or a whole body CT scan, they're getting radiation exposure across the whole body. If you're just getting your knee treated, that's a small field. Your hip, the genital area, the upper body, that's completely out of the radiation field.
Okay.
So that's also what limits the risk of issues like cancer, basically, from too much radiation exposure.
Right. So you're saying you don't know if I could come back to you 3 years from now and get it again, right? If I do it once, once the whole treatment course.
Once or twice, right? After 3 months.
And then we would evaluate on a case by case. If patient says, 2 years ago you gave me radiation,
it helped out a lot,
and it worked out great, and now I'm coming back, and this joint's causing me a little bit of issues again, we would consider it. Yeah, it's not one of those things that's so risky that we would blanket deny and say no, we wouldn't do it.
Okay. Now, as an orthopedic guy, right? Have you heard of orthopedic guys recommending radiation treatment?
Yeah. We just talked about one of my hand partners refers cases over. Women are a little more common than men on hand arthritis. So those small joints in the hand respond well to these low-dose radiation treatments. And again, we're just learning as orthopedic surgeons that this is a treatment option. And I've already got 20 partners that don't probably even listen about PRP or stem cells or biologic alternatives, because it's a newer modality in the last 10 years in North America.
Right.
So whether they would ever refer is really up to the doctor, his mindset of what can I do to help you? They're going to tell you to take tart cherry juice and try that on your hands, and some of these, little frankincense oils, like whatever has worked in other places. Some of the more, I guess, new age doctors would be more open to alternative therapies. And that's all we can do is try to educate not just the lay people, but the healthcare providers. And he doesn't care who sends him a case, whether it's a chiropractor, a physician assistant, a orthopedic surgeon, or a family doctor. They're all trying to get a patient to feel better for their problem. That's what we want to do in medicine, right? Do no harm.
We've had plenty of referrals from, as you were saying, orthopedic surgeons, referral from primary care physicians, and for us, if you think about us as radiation doctors, as cancer doctors, we are not interested in radiating patients unless we really believe we can help them. And so if we, working alongside our orthopedic colleagues, and have a conversation about a case, and the orthopedic surgeon says, listen, this is somebody who I really think surgery is indicated, we're going to stand down. We're going to work as a team. It's just trying to get the patient the right care.
Right.
At Kettering Health, we're not trying to grow some service at the expense of others or have turf wars or compete.
Turf wars,
that's not part of it. It's just not worth it. It's getting a solution to the patient, knowing that we as an institution came around them, solved their problem. That's what we're interested in, because that feeds on itself in a positive way in the community, that, the docs didn't fight, they communicated, and they did the right thing for me.
So,
Well, I'll tell you what else an orthopedic surgeon's going to be happy to know is that this doesn't cause any harm if we have to do your knee replacement later.
Yeah.
So that's important. He's not, mucking up the tissues
Right.
where they're not going to heal or we're not going to get a good result. So that's important for us that we're not, causing any harm down the road because eventually some of these joints will get worse. And over time, people live long enough or get the wrong injuries or accidents or whatever, you fall off a ladder, joints get traumatized, they get worse and more painful. Well, then we talk about other things.
So what this reminds me of for all you Star Trek fans out there, remember Dr. McCoy? Remember Dr. McCoy? He'd come in, somebody have an issue, he'd pull out this gun that looked like and he would focus it on the joint or place, and that was it. Isn't that kind of getting to where that was?
I mean, I'd love it if someday we get to the situation where instead of having these, big radiation machines that cost as much as a light business jet, like $3-4 million, $5 million, that it could be so cheap and available to patients in a widespread way. I mean, that would be amazing. Hopefully we get there.
Well, so go ahead.
Well, I was just going to say, this is literally in a big radiation room with a big rotating, what's called arm or a C structure. You're in an imaging area that's shielded, and it's not very mobile for sure. So you have to go to an institution that has the financial backing, the trained physicians and providers, and the dosage is accurately calculated. So this isn't going to be at at the local circus. So we need to we don't want to temper that. We should also talk about a couple other applications that we've seen. Some of the athletes have used it, right? Let's talk a little bit about painful heel.
Sure.
We talked about this painful heel syndrome called plantar fascia pain. We had our foot doctors on telling us to stretch our Achilles, but some of them really hurt. And when there are a few famous examples you could give us?
Absolutely. So, so plantar fasciitis, this is really bothersome inflammation of this, fascial sheath at the bottom, of our foot by the heel, as you were saying, John. So, so that's a similar situation. It is a chronic inflammation problem, and the radiation therapy with the exact same treatment schedule that I told you about before, the 6 treatments given every other day.
Right.
That's the most commonly used schedule to treat this as well.
At the bottom of your foot.
That's right, bottom of the foot.
Okay.
And it works really well. And a famous example, so I mentioned Germany already, and being a place where so many patients have been treated for these issues. So Usain Bolt is one of the most famous sprinters in running history. He won gold 3 times at London. I think that's the right order. And then he came back Beijing 4 years later and won three gold in the same 3 events again. So in between that, he had bad plantar fasciitis, and he went to Germany and he had radiation therapy. You can find little clips online of him getting treatment and the machine moving around him. And he said that it was a savior for him.
Really?
And he was able to come back and run again. And he's been quoted about it in various places.
Well, it's on YouTube, so it's got to be true.
Yeah, exactly.
And honestly, when someone has a treatment without surgery and then wins 3 more gold medals, that's what makes people pay attention, right?
Oh, yeah.
I mean, you're avoiding surgery. You own the baseball team with a guy with a painful heel. You need that guy back out there, right? Yeah. So, things that are safe alternatives that maybe you have to go overseas to find, people will do that, with the right research and the means.
So is it an educational struggle maybe for right now? People aren't hearing of this. Maybe the general practitioners aren't aware of it.
Orthopedic surgeons aren't hearing about it.
It's still relatively early years of this here in the U.S.
How do you spread the word? How do you get out there to tell this is a
podcast?
Come here.
This is it.
No, I've been invited and I've given talks to our various doctor groups around, and we, there was another a podcast, Dr. Attia, Peter. Is it Peter Attia?
Yeah, we were talking about his buckets. Remember? So
Yes.
he's really good for saying, is something proven? Is it promising? Is it just noise?
Yes.
Or is it just nonsense? And this is promising to me because it needs more research. It's not as proven as a stent opening up your artery in your heart, but it's not without evidence.
Yes.
So when you listen to things as a doctor or a consumer, you should say, well, is there science behind it? Is there a guy who's won a couple of Olympic gold medals behind it? Have anybody else used it, or is it nonsense like chewing bubble gum is going to help me do this algebra question better.
Right.
That's nonsense, or it's just noise in the beauty shop or golf course.
The reason I brought up that podcast is he had one of his buddies on, one of his radiation oncologists, because he lives down in Texas. So one of his friends, radiation oncologist in Texas, he had him on the show. And that obviously has a big audience. So that created a bunch of interest. A bunch of interest in this as well. And no, it's becoming more and more common enough that, the insurance companies are paying attention. As you're mentioning, the evidence development. So a bunch of randomized trials have been done and continue to be done in places all around the world, from Korea, where they did a recent study, Iran, Russia, been studies here in the U.S., studies in Europe. Out of all that body of evidence, there were a couple of studies that were done that were negative, and they were done in the Netherlands. And there's a bunch of critique of the studies about the doses used, about the short follow-up, low number of patients on the study, which makes it a lot harder to find a difference.
Sure.
Right. As opposed to a big study. So, but the preponderance of evidence is that it works, and it continues to show again and again. If you take 100 for every 100 patients that you give this therapy to, about 70, 75 of those patients are going to have a benefit.
That's fantastic.
Yeah, it's great.
Yeah.
Over 2/3, right? 3/4.
Yeah.
When we really look at what we should do as healthcare providers, we should analyze data. These studies are all over the place. More importantly, the people who review those for journals need to be on it. And we talked a little bit about some of the platelet-rich plasma studies that were poorly done, not enough blood was taken, not a high enough platelet concentration. Then the New England Journal publishes an article saying it doesn't work. Then the USA Today picks up a newspaper and says, see, it doesn't work. Well, it was a bad study. It should have never been published because the reviewer didn't look at the recipe. And when he's looking at radiation dosages or frequencies or how long, I waited 2 weeks and they weren't better. Well, you didn't wait long enough.
Yeah.
So a good physician or a good consumer will try to, kick the tires a little bit to say, is there evidence-based medicine? And that's what drives healthcare now. It should be, does the evidence support what you're doing? If it does, let's continue to explore it, right? And I think that's important.
Yeah, it's a great point, and that's something you see again and again, where there's a real drop off in quality. As you have these medical studies in high quality journals, and when they flip over to the regular press, the popular press, a lot of things get lost in translation.
I
there.
bet.
It's
Yeah.
really a problem. And I was thinking about this the other day, and your point reminded me of it. Is a big interest of mine is healthcare finance and health policy. We have very good publications that follow that world and make that world accessible to the public. But regularly, the New York Times, great newspaper, Washington Post, et cetera, they screw up and bad when they report on major medical findings.
Right. See,
It's
I'm
really
not
poor.
reading the New England Medical Journal, but I might see something in a publication that's more accessible for.
Well, they'll
normal guys.
access that article and maybe not summarize it properly,
Yeah.
or not even, or shouldn't comment on that because they don't really know it wasn't poorly designed,
Yeah.
or wasn't accurately designed. Tell us a little bit about some finger issues. There's an
yes.
affliction that draws the finger down. It's called like we talked about the fascia of the heel,
Yes.
which is a lining over the muscle. But actually, in Scotch-Irish heritage ancestry, it's a little more common, and it's called Dupuytren's contracture, and it was named for Napoleon's surgeon.
Oh, he wanted to get that in
who
there.
actually
dying
had
to
a
get that
coach.
in there.
The coachman had a contracture, and Dupuytren actually took a little penknife out and twanged this little band, and a loud snap occurred, and then the guy could use his hand, and he hadn't even discovered it. It was a different doctor, wrote up all the findings of a microscopic problem, but they named it after the guy who.
But
was
how would
famous.
radiation? See, I don't get how radiation
Well,
treatment.
he's going to tell you that. I'm just giving you the background.
Oh, he wanted to get that Napoleon surgeon in there. He was dying.
He's a great
to get
historian and medical historian. So for Dupuytren's contracture, which is, by the way, often mispronounced by everyone. You said it perfectly right.
Say it again one more time.
Dupuytren's.
Dupuytren.
Yeah, Dupuytren's contracture. So what's going on there is in the tendons, that go out to the fingers, there is a development of what we call like cords and even nodules, and these are resulting in this contracture, this pulling of the fingers back. Hasn't someone called this like the benediction hand, like giving a prayer? Something
Because
such
it
like,
usually affects the
Yeah.
smaller fingers.
Right.
Yeah.
And think of having maybe some duct tape around these little ropey things that bend your fingers. Well, they get sludged or they draw the finger down. So if it bends either of the knuckles at the bottom of your finger, you can't always open up your hand, so you look like the Pope.
Yeah, exactly.
Blessing
Giving a
people.
blessing.
But you get, you have trouble getting your hand in your pocket, or you have trouble getting it. So there are ways when it's really advanced and bent that they do surgery to actually remove the scar tissue. There are some injections that don't work very well, or don't always get used because they cost too much. But again, when we get things a little earlier than later in medicine, we have a better chance to control that inflammation. So we'll have a few slides behind us here that show some of those pictures of the fingers. But again, Dupuytren's is a newer area for what's called a benign condition.
Exactly.
But it's a
Remember, I
nuisance.
sent you my friend's picture not too long ago, and he had a bad case where it was like that.
Yes.
Trent, if you're watching, and I'm sure he is because he's looking for free advice.
It's worth what it costs.
It's worth what it's got. How does radiation
So
help that?
I will say straight away, since you're making the comment about an individual with a fairly severe contracture, is that radiation has been shown not to help once the contracture is beyond 30 degrees.
Okay.
So radiation does help when it's the early stage, as you were saying, John, where we can target these cords and these nodules that develop in the hand. And so what we do is, and as John was mentioning, it'll be on the slides. So what we do is we map out the location on the hand where these abnormalities are, and we develop the radiation field to match them exactly. And because it's the hand and it's very superficial, i.e. close to the surface of the hand, we actually use a radiation technique where we don't give photons, but we actually give electrons, because electrons are perfect for this. They interact with the tissue as soon as they hit it. So they actually give dose not so deep through and through the hand, but rather right at the surface as soon as the beam interacts with the tissue. And so similarly, by deactivating these cells that propagate this nodule formation and this cord formation, we deactivate them and then slow down that process. And we can actually reverse the process when it's early. Very important that for any folks who already have a severe contracture.
So what degree angle would that be?
That's well beyond 30.
That's about,
Okay.
Just think of a 90 is a right angle, right?
Yeah.
Exactly.
So 45 is there, 30 is a little less than that. But if once it, and you can't physically straighten it. Some of these are actually drawn down like into the palm.
Yeah.
And those are a little tougher surgeries. You want to have a doctor with a good set of what are called loops who can kind of unravel those areas of scar tissue. It's a very subspecialized form of treatment.
So before we jump out of this and get to the end where we want to ask you a little bit about the other podcasts that you're involved with, with all these fancy people that are coming on and talking about. What is it? What is the podcast about again? Kind of remind me what that podcast is about.
So the podcast is Value Health Voices, and I founded it together with a colleague of mine called Dr. Rawari, who's based in the D.C. area, to talk about all things health policy and healthcare finance, because these are the things that the government's doing, that insurance companies are doing, that just have massive leverage in our healthcare system, massive effects. They influence the entire country, and even in some ways influence what happens even outside the United States with policy, just because the rest of the world often looks to the United States and what's happening in our healthcare environment and may even develop their own approach to things based on what we do. We decided to do this because it's an interest that I've had for a long time, an interest that Amra's had. Both of us are involved in various policy functions. My colleague who I founded the podcast with is actually the RUC advisor for specialty. So he actually has to go to these meetings and defend the specialty as the treatments that we do get valued by the AMA. And so we developed over the years this experience, a detailed knowledge about where the power is, where it's not, what the government considers when it makes a decision, what they don't consider. And so we want to make it accessible for people to understand. But our audience is primarily people who are within the field. So it's not let's say a patient facing, but rather for managers and executives in healthcare, and for physicians who have an interest in understanding the economics of medicine better than the next guy.
Because normal guys, I'm not normal by any degree, but people like me think, why is it so out of control? Why are things not working? Why is it so just expensive?
Exactly.
Right. That's the kind of stuff that, we would all find fascinating to get into, but I'm sure you're probably deeper in the weeds than just that stuff.
Well, we talk a lot about that. In fact, coming up here next month, we're going to interview Mark Cuban, who everybody is household name now, and he's a big,
I love him.
Yeah, he's quite a guy, and he's very innovative, and he's putting a lot of pressure, particularly on drug costs, and particularly on a kind of drug middleman called a pharmacy benefits manager.
Yeah.
And,
All the insurance companies
and a
have
lot,
that.
yes, and a lot of things that he's done have led to reforms that have already even happened. And so we'll talk a lot about that and try to leave the audience member, folks listening to us, understanding very clearly what are the economics of drug pricing in the U.S. Why do things happen the way that they do?
That would be fascinating to listen to. You might find me sitting in the back listening to you guys on the next podcast.
I love that. Yeah.
All right.
Yeah. Well, we like to tell people a couple things. One is we want to make sure they know that all our social media platforms have some of the podcasts of his and mine. The videos on YouTube.
Right.
Yeah. Spotify, Apple, iHeartRadio, whatever you listen to on the radio. We also want to thank our sponsors. We've got 2 great sponsors. We've got Ted's Greek salad dressing, which is a great
We're supposed to
marinade.
bring jars to give to guests.
I know.
What happened to that?
Next time for sure.
Oh, my God.
And then we do want to thank Stiefel GWR Group. They're great financial planners, and they can help with some of the financial needs and the future navigation of earthly and space investing and monetary policy in your own backyard. So we appreciate our sponsors.
So why don't you leave us with how people can find you?
Sure. So, of course, if you want to come and you're in the Dayton, Ohio area and you want to have this treatment, you can easily find us by Googling Kettering Health and osteoarthritis or low-dose radiation therapy. As I mentioned, you'll find a patient intake form where they'll ask you some questions, and it will give you the opportunity to go ahead and straight away connect with us and be seen in our clinic. Of course, you can we'll link it up here and put it on your slides, perhaps.
Yes, we will.
The phone number, so the old-fashioned way.
The
folks can call
old-fashioned
us
way.
and self-refer. And again, if you're in the area and you have a primary care doctor that knows you have this chronic pain from your osteoarthritis, or an orthopedic doctor, let them know, and they'll refer to us as well.
And look around. You're in another country than the United States. You've heard this podcast. Somebody somewhere knows about this. We were talking about how many people here versus Europe are doing this type of treatment as radiation therapists or oncologists, and it's maybe 80% there and 10% here of radiation physicians. So we're trying to catch up a little with the rest of the world. But if you're in another part of the country or world, you've got to ask around and say, somebody somewhere is going to know. You can use your Google search engines or whomever you think is going to help you find that information. A lot of AI information out there. So, go find it, and that can help you or someone in your family or a friend that needs some of these safer alternative therapies.
All right. Well, Dr. Andrew Paravati, I want to make sure I'm pronouncing that correct.
Anthony?
Anthony?
Yep, you got it.
Do people call you Tony?
They call me Anthony mostly.
It's all right. They call me Terry, but my real name's Terrence, but feel free to call me anything you want. All right. Hey, folks, thanks for joining us on the Bone and Joint Playbook with Dr. John Urse. We'll see you again real soon on another episode.
Thanks for having me on.
Thanks,